This is Professor Ariel Ortiz-Lagardere streaming live from the International Bariatric Studios, and I am delighted to announce that today is the 129th IBC University of Oxford Surgery webinar. The IBC University of Oxford webinar series is a collaboration between the IBC and the Nuffield Department of Surgical Sciences, University of Oxford. The aim of the webinars are to provide free and first-class surgical education globally to improve patient care. In addition, the University of Oxford has allocated September 15th through the 17th of 2026 as the dates for the 7th IBC University of Oxford World Congress to be held at the Examination Schools, University of Oxford, UK. For more information, go to ibcclub.org. The theme of today's webinar, which will be streamed via the IBC TV tab on ibcclub.org, is Single Fire Stapling Technology at a Global Level, Improving Standardization and Speed in the Sleeve Gastrectomy, and will feature experts from the United States, Germany, and the United Arab Emirates. The IBC University of Oxford webinar partnership would like to thank Zoom Video Communications, Laparoscopic Surge, Bariatric News, and Bariatric Channel for setting up and promoting this regularly scheduled online academic series. We would also like to thank our platinum sponsors, Johnson & Johnson MedTech, XNY Medical, Arthrex, Reach Surgical. Our gold sponsors, Standard Bariatrics, Teleflex, Medtronic, Blue Sail Surgical, David Medical, McConvey, ConMed, Carl Storz, USGI Medicals, GI Windows. Our silver sponsors, Easy Search Medical Arabian Co. Our bronze sponsors, Olympus, Intuitive. The chair of today's webinar is Professor Shaneeta Johnson from the United States. Professor Shaneeta Johnson is Chair and Professor of Surgery, Department of Surgery, Mary Medical College, Tennessee. Associate Dean and VP of Global Health Partnership and Engagement, Professor of Global Health, Meharry School of Global Health, Tennessee, United States. I will now ask Professor Johnson to introduce our esteemed moderators.
Hello to all joining us from across the globe. It's my pleasure to welcome you to today's IBC University of Oxford webinar, Single Fire Stapling Technology at a Global Level, Improving Standardization and Speed in Sleeve Gastrectomy. As surgeons and leaders, we are constantly striving toward enhanced precision, safety, reproducibility, and equitable access to advanced bariatric surgery. And single-fire stapling technology is a compelling innovation, one that challenges us to rethink efficiency, standardization, and our long-term patient outcomes across diverse settings and populations. Today's program brings together renowned international faculty to dive deeper into the impact of this innovation of single-fire stapling. I'd like to thank Professor Ariel Ortiz for his introduction and for convening this session. I am honored to serve as chair and to introduce our moderators, Professor Fink from Germany, Dr. Tanya Kajese from the USA, and Dr. Javed Raza from the United Arab Emirates. Professor Fink is Professor of Surgery at Universität Klinikum Freiburg, Germany. Dr. Kajese is a bariatric and minimally invasive surgeon and chief of surgery at Memorial Hermann Memorial City, Houston, Texas. She's also assistant professor of surgery at the McGovern Medical School in Texas, USA, and president of the Texas chapter of the American Society for Metabolic and Bariatric Surgery. And Dr. Raza, our third moderator, is the director of the Bariatric and Metabolic Surgery Institute at Cleveland Clinic, Abu Dhabi. He is a staff surgeon at the Digestive Diseases Institute at the Cleveland Clinic, Abu Dhabi, and vice chairman of the medical charity Midland Doctors, who provides free medical and surgical treatment. So we have a dynamic lineup today of presentations that will examine reproducibility, reflux outcomes, regional challenges, and the engineering science behind single-fire stapling. I encourage everyone to engage deeply with the perspectives and insights shared today and to interact with us on our platforms. Let's begin this important conversation on the future of surgical stapling technology and its impact. I would like to introduce Dr. Professor Fink to introduce our first speaker, Dr. Enochs.
Well, thank you very much, and a warm welcome for all of you watching from my side as well. I want to introduce Dr. Paul Enochs. He is not only a past president of the ASMBS, but also founder of the first private bariatric service in North Carolina. He has vast experience in laparoscopic bariatric surgery, but also in robotic, primary, and revisionary cases. Today, he's going to talk on the potential rewards we get on performing a reproducible sleeve. Dr. Enochs, the mic is yours.
Thank you, Professor Fink and Dr. Harris, Dr. Ortiz, and the other moderators for the opportunity to speak to you all today and about the single fire stapling technology and what we have been able to see with that. So I'm going to start here by looking at when we start talking about single fire sleeves, what is the rewards of reproducibility in gastric sleeve construction? And that's an important question. The following are my disclosures, along with relevant disclosures. And when we start looking at sleeves, what we have found, especially with the MBSA equipped database and other things, that there are hundreds of ways to make sleeves. And if we look back at our data, what we have found in 2019, 2020, when they were looking at this, there are over 106 different variations of at least 100 cases each on how we do sleeves. And if you look at the top variant was doing a sleeve over a 40-French bougie, 5 staple loads, no oversew of the staple line with staple line reinforcement. Yet that represented less than 8% of the cases done. When you start looking at overall, there was about 9 variants that had over 2,000 cases each, and yet to add up at least 17 different variations of how you do a sleeve to just get to 50% of the cases done here in the US. And when you have these variations in procedures, you have variation in anatomical output. We're all trying to get a nice tubular looking sleeve. That's what we're shooting for. But unfortunately, based on how we do the sleeve, you can have a lower pouch, an upper pouch, a dumbbell, and all these can lead to strictures and problems with our sleeve, because the issue that we have is we have a floppy, stretchy, two-sided organ, and we're trying to use short staples to create a straight line. Now, when you start doing this, where do I aim my next staple fire? How close do I put it to the bougie? Where should my assistant grab? What direction should they pull on the stomach? How hard should they pull on the stomach? And the problem end up with is when you start looking at from a surgeon, all those variables come into 5 degrees of freedom of articulation, rotation, XYZ position of the stapler, and the assistant has the same issues as they're pulling. And when you start looking at those 10 degrees of freedom, as you add each cartridge, you end up with variability that can amount into the millions of how you can create a sleeve. And as a result, with our current stapling techniques, with multi-fire staples and how we do this, although originally the staplers were designed for small bowel and large bowel where you could come across it completely with one firing, when you have a 23, 24 centimeter organ, the issue is going to be trying to do that same issue with multi-fires. And what you see is as the assistant is pulling and you're trying to get the jaws of the stapler in place, the idea is to have everything in the same plane. Yet if you pull too high, pull too low, pull too tight, pull too long, well, you're going to end up with all sorts of issues with your staple line, which is what happens and what you lead to with spiraling. And so what ends up happening is our goal is to get this picture that we have on the left, yet in reality, we see something that we see on the right. Now, all of us look at that and go, that's an awful looking staple line, and we'll never do that because as surgeons, we always try for what's better. So I went ahead and I thought the same thing. So back in 2020, I went back and looked at one of my sleeves, and this is a sleeve that I did in 2020. And when I did this sleeve, this was actually a video that was being done of a SADI procedure that I knew we were videoing. We were going to save this video and we're going to be using it from an educational standpoint. So I'd already done the duodenal ileostomy and I was just doing the sleeve now to complete the procedure. Now, when you look at this, this is probably my 3,000th sleeve that I had done. I'd been in practice for 18 years. We were doing sleeves all the time. It was our most common procedure at the time, back in 2020. And so what we see here is, I have a trained assistant. I'm trying to make sure every single firing is lined up. I'm firing my 6th load here, and I realize, not quite completely across once I fire this 6th load. So I bring my 7th load in to complete my sleeve. And now I've completed my 7 loads. I've now completed my SADI procedure. We check it. Everything's in place. And I'm like, I don't, there's that little kink, that little place where it turns up. But, overall, it looks pretty good. And I'm thinking, hey, that's not bad for my SADI procedure. And so I want you to remember that because we're going to come back to that. Now, again, the issue is we're trying to create this picture that we have on the left, yet we end up with all these variations that happen based on how we're pulling on the sleeve and what we're doing with the sleeve. And each of these things can lead to reflux, can lead to weight regain, can lead to decreased satiety, increased hunger. And on top of that, the FDA itself has said when you're doing GI procedures, every attempt must be made to avoid crossing the staple lines. Because when you do that, there can be an increased risk of leak. Now, it's next to, if not, it is impossible to do that when you're doing a 23 centimeter organ with 6 centimeter staplers. It's impossible. And so what happens here is the only way to comply with what the FDA has said back in 2021 is to see if we could use a single fire stapler to do that. Because our goal is to get this anatomy-based sleeve. We want to be a centimeter from the GE junction, 3 centimeters from the angularis, 4 to 6 centimeters from the pylorus to create this nice tubular structure. And we do want to do this in a continuous line, same plane, consistent shape, safe distances from key landmarks, and square it off. And you want to do that with multi-fire staplers, which become very difficult. As a result, to help with that, in 2017, a clamp was developed where we could put that alongside an NG tube, which would line up our stomach, and we could use multi-fire staplers to create that anatomy-based sleeve. And we did about 13,000 procedures across the country, and we started to see improvement in nausea, reflux, and other things by creating that anatomy-based sleeve, yet the staple line still crossed because we were using multi-fire staplers. All of this got changed when in 2021, the single fire stapler came along where we put staplers inside that clamp. And now we ended up with a procedure where now 20,000 of these single fire staplers have been done. And one of the things we're going to hear more about the engineering behind this later on when we talk to Adam, who's the engineer who helped develop a lot of this. But what you'll see is that the staple height increases with every staple that's thrown along the length of the stapler. So you're not just sitting there with a one size load throughout. You're going all the way from what would be a white blue load at the tip to what in the antrum a black green load. And so we went back to that week in 2020 where you saw my 3,000th sleeve being done, and that was on a Tuesday. It just so happened we were part of the FDA trial, and on Friday of that exact same week, I did my first firing of the single fire stapler. And this is that picture right here. And one of the things you'll see is we had a room full of assistants and nurses and people that have seen thousands of sleeves. And when we opened this stapler for the first time, everybody just looked at that and said, wow. Because what you had here was on the left, a procedure that was done Tuesday by me, and it was my 3,000th sleeve that I had done. And on the right, 3 days later, my first sleeve being done with the single fire stapler. And obviously you can see a dramatic difference there in those two staple lines, which made a believer out of me. Now, here we're going to see a video of the entire procedure. And this is done by Dr. Tanya Kajese, one of our moderators, which shows her technique of utilizing a single fire sleeve laparoscopically. And in this video, you'll see we're taking down, she starts by looking at the GE junction, ensuring there's not a hiatal hernia, taking down the fat pad. Usually about 4 to 5 centimeters from the pylorus is where we start our transection. Many of us will take a marker and kind of mark that spot just so that we can see it and just so that we can kind of visualize that when we bring our stapler in. We then start with our energy of choice to go ahead and start taking down the short gastrics. And then as we take down these short gastrics and mobilize the greater curve of the stomach, one of the things that is important, and one of the things that you're sort of forced to do with the single fire stapler, is to take this all down in its entirety. You want to take down all those posterior attachments, want to mobilize that entire fundus, because if any of those things are left behind, you're not going to be able to get the stapler on properly. And many times when we have staple lines with the multi-fire stapler that don't look quite right, it's because we've left some of these posterior attachments, we've left some of this fundus up here along the left cruce of the diaphragm, and all those things are important. So once the stomach is mobilized, the stapler is brought in through a 19 millimeter trocar just to the right of the umbilicus, and the stomach is positioned in place. Utilizing your assistant, a hand-over-hand technique is done to bring the greater curve of the stomach into position, and then the fundus is grasped and pulled posteriorly so that the stapler is in position. Once it's in position, the bougie is brought down to ensure that we have adequate distance from the lesser curve and we're off the annularis. And then the stapler is positioned appropriately and closed. One of the things that's nice about the stapler is that you can see what that entire sleeve and staple line is going to look like even before you fire your first firing. We then position accordingly, look underneath, make sure there's no retained fundus or any tissue that's bunched up between the stapler and the bougie. Once we ensure everything is in place, we'll go ahead and position the bougie appropriately, make sure it's not been caught, and then we'll go ahead and fire that stapler. And then once we fire that stapler, the reveal shows a beautiful, well-formed, consistent staple line that is reproducible. You'll see this doesn't look much different than the sleeve that I did several years before. And that is what we find when we do this single-fire stapler, the reproducibility of it. Okay, we're going to finish off here with this talk by looking at the fact that, okay, we know the staple line looks beautiful, but how does that translate to clinical outcomes? And now that 20,000 procedures have been done, we start to have these clinical outcomes. And here's a study done by Dr. Schramm up in Michigan in the United States. And his practice had it was a high volume institution with 5 surgeons, and they looked at their data. They looked at their multi-fire stapling with buttressing compared to their single-fire stapling without buttressing. They propensity matched both patients, and what they found was the statistically significant improvement in operative duration, length of stay, readmissions, and leaks. All of those were statistically significantly less with the Titan. Nausea vomiting was about the same, but one of the reasons for that is because he had been using the clamp on his multi-fire staplers. And so you were already getting the anatomy-based approach. But when it came to bleeds, one of the things that's important is, although it was statistically the same, it's important to note that the sequential firing was with buttressing, whereas the single firing was without buttressing. And so we're starting to see this data starting to prove the fact that with a better looking sleeve and a better looking staple line, you're getting better outcomes. And actually, the father of the sleeve, Dr. Michel Gagne, actually looked at this and talked about this even before the single fire stapler came along. And he said a technically perfect sleeve without any twist or stenosis should be ultimately the goal of anybody doing a sleeve gastrectomy to limit the risk of GERD and leak. The use of a specifically designed stapler will allow, after proper and complete dissection of the fundus and of the stomach, a single stapling shot, which will probably decrease significantly the risk of leak and stenosis after sleeve. The combination of this perfect technique with the optimal stapler and the ideal choice of cartridge will give the opportunity to perform this surgery routinely as a day surgery for almost all patients. He's published this in 2020, before this stapler was even around, in a book titled The Perfect Sleeve Gastrectomy, a clinical guide to evaluation, treatment, and techniques. And so that is our goal every time we do a sleeve, and we find, and at least in our hands, that the single fire stapler can help achieve that. Thank you.
Thank you very much, Dr. Enochs. That was an excellent presentation, lots of great data. Did you see any differences in weight loss with the single fire stapling? And then my follow-up question is, how do you see this reproducibility playing a role in training of our fellows and early career bariatric surgeons?
Sure. No, I think that's a wonderful question. In our hands, what we found is there was not a statistically significant difference that we could see when it came to weight loss between multi-fire and sleeve. We found basically they were equivalent, which is good. That was our goal, to show equivalency between the two. I do think that was immediately, and that was, obviously, over the first few years. I do think now, as we start to see longer term outcomes, because we have a more consistent sleeve without potentially any retained fundus or antrum, and without any of those, lower pouch, upper pouch issues, we are now getting into situations where we may not see as much of that weight regain. As far as from the case of younger surgeons earlier in their career, I think what this does is it helps to standardize the procedure. So now you have surgeons who are younger in their career, who may not have the experience of surgeons who have done thousands of procedures, being able to get a more reproducible sleeve that has less of the issues that could be seen with the sleeve, and thereby allow them to get more consistent, good-looking sleeves that can give better clinical outcomes.
Dr. Enochs, in the study that you shared, you had emphasized that there was a comparison between buttressed multiple fire stapling technique and then a non-buttressed single fire. One of the questions from the audience was if the Titan stapler does have reinforcement options.
That is a great question. Thank you, Tanya. Dr. Kajese, is one of the things that we do find is that when you start looking at the Titan, even though the study that we showed that there was no clinical difference between no buttressing with the single fire and buttressing with multi-fire, there is buttressing available for the single fire stapler. This was done because many surgeons, myself included, enjoy using buttressing. We've used it our entire career. We feel much more comfortable with it. And so there is a buttressing made by Gore Seamguard that is very familiar for many surgeons, that can be placed on the back table so that when the stapler is brought in, there's no strings or anything on it, and the single fire is done, the buttressing is in place.
Dr. Enoch, excellent presentation and very, very impressive data. This webinar is being seen all over the globe, and in a larger part of the world, the economy plays a bigger part in decision making. And how does the single stapler compare in cost and sort of reproducibility or availability at a lower cost? And that will be a very relevant question in a significant part of the world.
That is an excellent question, and definitely, I know I was in the Middle East recently with Dr. Raza, and I know that cost and different things like that are very important, and not only in the Middle East but around the world. And one of the things that we can say is that when you start looking at this device, the cost of this device, ends up being comparable, at least here in the U.S., to the cost of, if you're using 5 or 6 loads, the cost ends up being comparable. Now, if you're using the robot, the cost is actually less. And I know Dr. Ringold is going to be doing some talks about the robot and showing how you can use the single fire stapler with the robot. The cost is less than 5 or 6 robotic loads. I do know that around the world, the cost of some laparoscopic loads can be much, much less than it is here in the US, with different companies that aren't here in the US. And so as a result, that may be a relevant question. But then you start looking at long-term issues. If you're getting better sleeves with better data, lower risk of complications, lower risk of regain, lower risk of reflux, then that tends to balance out those issues that are around cost because you're getting a better sleeve.
Well, thank you very much, Dr. Enochs, for your presentation. We're going to move on to the next speaker, and it's my pleasure to introduce to you Dr. Forrest Ringold. So Dr. Ringold is a certified general surgeon and bariatric specialist in Mobile, Alabama. He's currently the president of the Alabama State Chapter for the American Society for Metabolic and Bariatric Surgery. And he actually leads the epicenter at Mobile Infirmary in Alabama, USA. He's going to be talking with us today about, can single fire stapling technology actually impact reflux after a sleeve gastrectomy? Dr. Ringold, thank you for your time today. Oh, Dr. Ringold, I think you just need to unmute.
Yeah, thanks. Thanks so much for the introduction, Dr. Kajese. It's an absolute honor to be here today to talk to everyone about this topic and to be among the distinguished other speakers and moderators. Just delighted to talk to you today about our topic, which is, can single fire stapling technology impact reflux incidence after sleeve gastrectomy? So these are my disclosures, which are not pertinent to the talk today. As we all know, sleeve gastrectomy is a excellent bariatric procedure and is the most commonly performed worldwide. In the study, 60.4% of our bariatric procedures are sleeve gastrectomy, followed by gastric bypass and then OAGP. And I think that's because it's a very straightforward technique for the surgeon. It's easy for our patients to understand what we are going to be altering. And it's easy for our patients to get their head around the procedure. There's no anastomoses created. There's no rerouting of the intestine, and it provides excellent weight loss. But having said that, there's certainly potential for improvement. And Dr. Enochs has nicely illustrated the variability among sleeve technique. And it really would be nice to be able to develop a standard of which we could really perform and have very similar outcomes as far as complications, postoperative nausea, vomiting, leaks, strictures, things like that. And it's not just the variability among surgeons, it's also variability for myself. When I was using a multi-fire technique, sometimes I would use 4 cartridges, sometimes 5 cartridges, sometimes 6 cartridges. So this variability obviously affects the sleeve pouch, the volume of that pouch, and I often wonder with that variability, how does this affect long-term outcome, and how does it affect perioperative complications? But the other potential for improvement certainly is post-sleeve reflux, and that's the topic of our talk today. There have been numerous studies in the literature to outline the incidence of post-sleeve reflux. This is just one study in the Annals of Surgery in 2020, where they show a overall GERD rate of 19%. And I suspect that is actually underestimated because I am familiar with a study out of the state of Michigan and their collaborative group where they reported 1 year post-sleeve GERD HRQL scores, and 31% of all of those patients who underwent sleeve gastrectomy had worsening scores. So de novo reflux, you can see, is reported here at 23%. But really, the most concerning thing to me is the long-term esophagitis rate, as well as the Barrett's esophagus rate. So there's many reasons for post-sleeve reflux that have been studied in the literature. And this study looked at what happens on high-resolution manometry after sleeve. It's quite interesting. You can see shown here there's a reduced lower esophageal sphincter pressure. There's actually a shorter intra-abdominal segment of lower esophageal sphincter, and there's an increase in the esophagogastric insertion angle. And so all 3 of those things facilitate retrograde flow back into the esophagus and can create that 28% esophagitis rate. And if you combine that with some technical issues for the sleeve gastrectomy, such as creating a narrow sleeve or violating the phrenoesophageal membrane or not recognizing that the patient has a hiatal hernia, the risk of post-sleeve reflux rises exponentially. I thought this was an interesting article. This was produced by the Journal of American, or published by the Journal of American Medical Association back in 2020. And again, this was out of the state of Michigan also. Quite an interesting study where surgeons were blinded and evaluated videos of sleeve gastrectomy procedures. And they compared those videos to outcomes. And specifically on this slide, we're looking at 1 year outcomes as it relates to reflux. And they actually found 3 different technical aspects of sleeve gastrectomy that will increase the risk of reflux. And one is retained fundus or inadequate dissection in the proximal stomach. The other was creating too tight of a sleeve or stapling too close to the bougie. And then lastly, when the videos showed that there was a very small amount of antrum remaining, those patients tended to have significantly more reflux. As far as the pathophysiology of sleeve reflux, there's been multiple studies looking at this. And disruption of the phrenoesophageal ligament has been felt to be a major contributor to reflux. It disrupts the angle of His and allows for the naturally produced acid to reflux back into the esophagus. And just by creating a sleeve, maybe the perfect sleeve with the perfect sleeve diameter, just by doing that, we create increased intragastric pressure due to reduced gastric compliance. So that can lead to reflux as well. Sleeve shape certainly plays a role. When we inadvertently create a stricture or angulations or hourglassing of the sleeve, it tends to create gastric retention and decreased emptying, which can also lead to reflux. And again, not recognizing a hiatal hernia can cause reflux because if you think about it, we're leaving the lower esophageal sphincter in the mediastinum and also probably leaving some redundant fundus. So these are all things that I have incorporated into my practice over the years to try to eliminate post-sleeve reflux. I always try to preserve the phrenoesophageal ligament. I aggressively treat hiatal hernias. I probably am more aggressive than most bariatric surgeons, and about 40% of the time I will explore the esophageal hiatus and do a circumferential mediastinal dissection, even when I just see a dimple anteriorly. When I was doing multi-fire sleeves, I would perform an omentopexy, thinking that that may eliminate any subtle kink or twist and straighten out the staple line and help reduce reflux. When I do hiatal hernia repairs, I would always perform a posterior gastropexy to the median arcuate ligament as well. I actually, over the years, have upsized my bougie size from 36 to 40. I always recreate the angle of His by taking a suture, placing it in the proximal stomach, and connecting it to the left cruce. And of course, I try to create a uniform sleeve without kinks or twist. And I usually will start my sleeve at about 5 centimeters proximal to the pyloric sphincter to try to preserve as much antrum as is reasonable. And I must say, this is a lot of stuff, but this is what I have come to over the years, all in an effort to try to reduce the incidence of post-sleeve reflux. And when I looked at my data, I was pretty disappointed. I still had 24% of my patients taking PPIs. So quite disconcerting. Dr. Enochs showed this slide earlier, and he and I have kind of taken a similar pathway over the years as we approach sleeve gastrectomy. And I also adopted this anatomy-based sleeve gastrectomy approach because I had exhausted every other thing that I could think of to control this reflux problem. And so I started to feel like, maybe the sleeve shape really matters, and maybe if I can get more of a uniform diameter sleeve, that there would be less gastric fluid retention, and we could see some improvement. And as he mentioned, as I did this, locating the key anatomical landmarks at the GE junction and at the angularis insensura and the distance from the pylorus, the first iteration of the Titan was the standard bariatric clamp, and I used that first and ultimately went to the Titan. But I can tell you, just anecdotally, it was not long after I adopted this approach, and again, after having doing all of these other maneuvers to try to limit reflux, not long after I did this, we saw a clinical improvement. And I have a nurse practitioner that works with me in my office. She does not go to the OR with me, so really she's blinded to my technique. I don't really talk to her about what my techniques are, but she sees all of my patients post-operatively. And she came to me soon after I adopted this technique, and she said, "Hey, what are you doing differently down in the OR?" And I just kind of chuckled, and I said, "Well, yes, I have changed something. Why do you ask?" And she said, "Well, your patients are having much less post-operative nausea and vomiting, and I'm not putting them on PPIs anymore." So really thought that was very interesting. As we progressed through time, the Titan was introduced, and again, Dr. Enochs has gone over this a little bit, but the things that I would point out to you is that this is a 23 centimeter stapler. It fires 3 rows of staples on either side of the cut line, and it fires in the opposite direction that you may be familiar with. It fires from the hinge towards the handle of the device. But we've really enjoyed using this device. And you saw a video earlier of the laparoscopic approach, and I just wanted to point out a couple of subtle differences with the robotic approach. I do all of my procedures robotically. This is my trocar position, and I use a 19 millimeter trocar, which is required to place the 23 centimeter stapler. And you have to place that trocar far enough away so that you can place the stapler intra-abdominally and have plenty of room to manipulate it. And for me, that sweet spot is about 27 centimeters inferior to the xiphoid along a tangential line, kind of mid-clavicular line. That works for most people. And then the other arms I place about 17 centimeters inferior to the xiphoid. And again, that seems to work pretty well for most people. And I wanted to just show a short video of performing this procedure robotically. And similar to Dr. Enochs, this is my very first Titan sleeve. And you might wonder, why are you showing me this first Titan sleeve? And I think it's important for everyone to understand the simplicity of the technique and the ease at which a multi-fire sleeve gastrectomy surgeon can start using this single fire 23 centimeter stapler. Now, I have already made my anatomical marks on the stomach, and all I'm doing is lining up those marks. My RN First Assist is actually handling the stapler and has easily put it in, and she basically just stabilizes the stapler while I use my number 1 and my number 4 arm as traction, counter traction to manipulate the gastric tissue in the stapler. I do my safety checks, and then we fire the stapler. It is quite straightforward of a procedure. And again, this is my very first one that I ever did. Just very easy to do. And I would kind of emphasize what Dr. Enochs said earlier, in that if you don't really like the way that the sleeve looks, you can get an idea, or you can know exactly what your sleeve looks like before you fire the first staple. And if you don't like the way it looks, you can just open the stapler, manipulate the gastric tissue, close it down again, and fire it. So that is a little different from the multi-fire approach. So I mentioned to you that anecdotally we were having some positive clinical outcomes when we changed our technique. And so we really wanted to see if our perception was reality. And so we did a retrospective study of my cases. And the outcome we wanted to look at was reflux at 1 year post-op. And we were honored to have this published in Obesity Surgery earlier this year. So this is our methods and our data. It's basically 2 cohorts. So I used my very best multi-fire sleeve gastrectomy cohorts. These are my latest sleeves after I've done thousands of sleeves, after I've incorporated all of those reflux reducing maneuvers that I talked about earlier, and compared it to my very first series of single fire stapling. And in each cohort, I used a 40 French bougie, and I aggressively repaired hiatal hernias, as I mentioned earlier, and I performed posterior gastropexy. And so we collected all of this data in a HIPAA-compliant Excel spreadsheet, and we looked at GERD symptoms both preoperatively and postoperatively at regular intervals. And we recorded GERD as it existed based on the patient's symptomatology of heartburn, reflux, and regurgitation. And we also recorded reflux medication use, and we compared PPI use between the 2 groups. And we felt like using PPIs as our marker for reflux was a very practical thing to do. I know that, when people are really miserable, they're going to seek treatment, and that's significant reflux. And when people come in and they say, well, yeah, maybe I had reflux, but it was after I ate too much, and it's really not that bad, and I don't really need treatment. They don't have reflux. And, the quantitative testing that we do is quite expensive, it's quite invasive, and it really is impractical to perform, especially on a patient that is post-op doing great, totally asymptomatic. It's going to be incredibly difficult to get them to do some type of invasive test. So that was our study design. There really wasn't any difference in age or gender or comorbidities or pre-op GERD symptoms. And so these are our results. And what you can see immediately is that we had a substantially reduced rate of de novo reflux in the Titan group, 1.8% versus 10.9%. We just had an overall lower rate of reflux in general in the Titan group, 7.1% versus 26.4%. And then we had an overall increased resolution of reflux at 1 year in the single fire group at 25% versus 10.9% in the multi-fire group. And all the other variables, the length of stay, the comorbidities, and the readmissions were very, very similar. So this is just another way to look at this data. And the red is the single fire group and the blue is the multi-fire group. But the differences were pretty significant. And I think this kind of validated what our anecdotal experience was earlier. We really are seeing a tremendous improvement post-operatively. One last thing I would mention to you is that's kind of interesting is we did a multiple logistic regression analysis looking at several variables, and we wanted to see if we could identify a variable that would be a strong predictor to eliminate reflux postoperatively. And as you can see here on this graph, we found two things that were the strongest predictors to not have reflux at a year post-op. One were individuals that did not have pre-op reflux, and the other variable was individuals who had a sleeve gastrectomy with a single fire stapler. So, in summary, I would say I've been in practice for 24 years now. You can see all of the things that I have tried to do to eliminate reflux over the years. The thing that has made the biggest impact by far has been sleeve shape. And you can look at these sleeves and say, I think they look really good. And you can look at it and say, well, does that really make a difference? My answer personally is yes, it does make a difference. It makes a significant difference. And I think it makes a clinical difference that patients are going to have less reflux. And for me, the best way for me to be able to consistently create this type of sleeve is to use that single fire stapler. So thanks so much. I appreciate your attention, and I'll be delighted to answer any questions.
Thank you so much, Dr. Ringold. Great talk. Love seeing your data. You mentioned the technical aspects and you mentioned the sleeve shape. Do you think the firing from the hinge has anything to do with the reduced incidence of GERD, so that there's not as much bunching of the tissue, maybe at the GE junction area? What do you think is really giving so much of this difference that you were able to show in your data from the work you're doing?
No, Dr. Johnson, thank you. That's a great question. And I think that's an interesting hypothesis. I've never really thought about it that way. One part of my procedure that is a little bit different with the single fire technique is that I do take down the fat pad around the GE junction. And I always want to make sure that I'm at least 1 centimeter away from the gastroesophageal junction. I always want to try to preserve that phrenoesophageal membrane. And I always want to make sure that I've mobilized that fundus completely. I always want to see that left cruce. And I just think all of those things combined really help limit the reflux. And certainly what you mentioned, that may play a role. But I really think that limiting and reducing the hourglassing effect of multiple 60 millimeter staples really improves outcomes.
Dr. Ringfold, excellent presentation and very impressive data. You mentioned in your talk that prior to using a single stapler, you did a lot of extra precaution steps, including dissecting the hiatus. And are you still doing that with your single fire, or you've given up on that side of the practice?
Yeah, thank you for the question, Dr. Raza. I am, and I didn't mention that when I was reporting the data, but if you look at the 2 cohorts, and I can't remember the exact number, but the incidence of concomitant hiatal hernia repair in the 2 cohorts is the same. I think it's around 40%. So you might think that's aggressive. A lot of my colleagues think that that is aggressive. And I'll be quite honest with you, I was doing that before I started using the single fire stapler in an effort to reduce post-sleeve reflux. And, now I am starting to think that maybe I don't need to be so aggressive with repairing so many hiatal hernias, and perhaps the single fire stapler is really what we need to do to reduce that post-sleeve reflux.
Thank you very much. So that was a great presentation, and now it gives me a great pleasure to introduce our next presenter, Dr. Girish Juneja, who's a senior bariatric surgeon with more than 30 years of surgical experience. Presently, he's leading bariatric surgeon in Fakih University Hospital in Dubai. He was director of bariatric services and head of surgery department in various reputed hospitals in Dubai and Abu Dhabi. And his topic today is challenges and outcomes of sleeve gastrectomy with single fire stapling in the Middle East. Dr. Girish, the stage is yours.
Thanks, Dr. Javed, Ahmed, Raza, and welcome and thanks to all the moderators and fellow speakers here. And thanks for inviting me to, and thanks to IBC also. So let me share my presentation. Is it clear and audible?
We can't see your presentation.
Really? Now is it okay?
Yes, we can see it now.
Fine. So let me put it into the presentation mode. Yeah, I think should be okay now.
It's perfectly fine. We can see you
Fine.
well.
So coming back to my topic, challenges and outcomes of sleeve gastrectomy with single fire stapling in the Middle East. So basically, I will be orienting around any problems or any variations we should do with this stapler, single stapler, as per the patient. So this is my disclosures. Now coming to the Middle East, it's a home to staggering number of nationalities. For example, in Dubai, if we talk, it's more than 200 nationalities are living here. So it's a true melting pot of cultures with the expats making up to around 85 to 88% of its population. Now, this brings different barriers and variations also, like language barrier, cultural differences. For example, if we talk about body fat distribution, central obesity is more common in South Asians, whereas visceral fat is higher in Middle Eastern patients. And of course, anatomical variations also we have to keep it. So surgeon who's practicing bariatric surgery not only needs to adapt techniques to accommodate anatomical variations, but also needs to understand cultural and social factors also. And accordingly, he has to plan reinforcement, planning of the surgery, and post-op care attention, which is very, very important. Now, for example, giving example of gastric wall thickness, we have lots of patients from Africa also. So the thickest stomach we find in African stomach wall. And for example, in the Asian descent, if we talk, the stomach is smaller capacity. So these factors we have to keep it. And one factor which we want to show racial wise, the gastric wall thickness is thickest is in the African patients, then comes to the Asian, and then comes to the European. So variation comes with these factors we have to consider. Now, again, I'm showing you, third time you must be seeing this stapler. Now, stapler, it's an engineering marvel. Mr. Adam will be showing you again and discussing about it. So my journey started with this single stapler before last year. I remember before COVID, I used to do Medtronic staplers, and they had a meeting with bioengineers. And I was also sitting there. So they were asking the um, different suggestions from bariatric surgeons. So I told them that instead of multiple firing, why don't you make single fire? Longer fire was at least longer than what we are using it. So the bioengineers who were there, they smiled. They told doctor it is not possible. And they were talking about the forces and all that, how is not possible. So when I came to know about this stapler, I was very excited. And then when I learned about this, I met Mr. Adam also and wanted to know how he invented out of box. So this is the story regarding my association with single stapler. Now, it is a little bit exaggerated by inflating, but you see the difference between multi-fire stapler, the small kinks, when we distend, they become very prominent. And on the right side, you see the straight stapler, very curved stomach. And as the previous speakers have spoken, it has bearing on outcome, not only nausea, vomiting, about complication rate also. So that's the difference coming with this here. My experience in Dubai and Abu Dhabi to broad population, which I discussed, all stomach shapes and sizes we have done. So variation of BMI comes from between 37 to 60. Improved patient condition post-operatively compared to multi-fire, which I have noticed in my patients. Less nausea, vomiting, of course, reduced operative time, and no readmissions happened here. Even the longer specimens, which the picture is showing, we have done without any trouble. Now, let me come to the cases which shows how the variation can happen with the patient to patient. The first case, which I'm showing the video also small, is a female patient, age 35 years, height 145, and 92 kilograms weight, BMI is 42. So it's a short stature patient. And then when we did the surgery, I'll show you the small video. So we were a bit cautious. We started with the slow dilatation of the trocar site rather than straight going with the main trocar. So we have done the 10 mm, and then we took the trocar, main trocar, and inserted. So you can see the space is very less, and we took our own time. We don't want to do any injury inside, so we were very cautious. So you can see now it's coming up. So here we are entering, of course, very cautiously because space is very less. And then we wanted to see whether that stapler will fit or not. So we have gone through the grasper to see the direction, space, and the distance. Once we were comfortable, we introduced the stapler. So here the stapler is coming up. Of course, you can see space is very less. We have to increase the pneumo pressure also. And then we did head down rather. So it's almost touching the diaphragm. And still we have to push a little bit so that the red ring is inside. Now this is the maximum we can do it, and then we check that. Oh, sorry. What happened? Oh, some technical problem. Yeah, sorry. Sorry about that. I'll play again. So once we were comfortable, then the rest of the surgery happened, and we were successfully able to do that. I'll skip and make it faster because of time. Little bit friction with the liver also, but ultimately it went well. So the next case is a huge liver. Despite 6 weeks of preparations, all kinds of diets, exercise we did, and now you can see the huge liver is there. Despite with the liver retractor, there was no space. The whole abdomen, it was going below the stomach, below the umbilicus also area. So we have to move the port size more down and more medially, thinking that it might help us in putting the stapler. And yes, with this change of side, we were able to negotiate. So again, I'll make it fast forward. So once we were there, then there was no problem. After adjustment of trocar side, there was no problem coming up. Yeah. So this was a specimen done very nicely, and sleeve you can see it was beautiful. Of course, the huge liver was there, and the stomach specimen was also long, but was done nicely without any problem. Now coming to the next case, this is more of a some of you must have come across. I was firing, and then after fire, first time I felt little uncomfortable. That sensations were not like what I used to feel while firing. So it was just a hunch, my gut feeling, you can say. So I never usually cut the specimen. Then later on, I took the specimen. I told I want to cut and see what was the difference. Everything is same, or my gut feeling was right. So this was the thing when we cut open it. So we asked the patient also that despite all the instructions by doctor, by coordinator, by nurse, why this happened. She told, my friends told that after surgery, you whole life you will not eat, so let's have a party. And she had a nice minced meat on that night, late night even. But luckily, patient recovered well. We had no complications, and you can see that power of cultural and ethnic competency in surgery we have to take care in this region also. Yeah. Thank you very much. Yeah.
Thank you so much for this great presentation. We do have a couple of questions that came from our viewers.
Sure.
And one is about the different heights, staple heights. And with multiple stapling fires, you can use different heights for each staple load. How is that accounted for with the single fire stapler? And also, is the 19 millimeter trocar supplied with the stapler?
Yeah. So regarding the staple heights, I think we were still people are using, and we were using also multi-staplers. So basically, we used to have our own feel that no, I should use the black one or the green one or the blue one. So of course, we can choose. We can step up while doing surgery at any point. We can choose lower or higher height. But I will say that more of a guesswork or more of a gut feeling. Yeah. Here, this stapler, Mr. Adam is going to explain you. This stapler is based on very scientific studies whether on the animals or in the labs or the burst pressure or everything. So I think based upon all the scientific studies and inferences, they have come with this staple. So I think we should go with their studies, which is science-based. And till now, my personal experience, if I say, there's no problem. It works very well. And the height, the staples goes very well with the stomach at different sides of the stomach wall. Yeah. Now,
Dr.
second part was regarding, sorry, can you repeat the second part?
Regarding the 19 millimeter trocar, if
Yeah,
that comes with the stapler.
yeah, 19 mm trocar stapler. To introduce a stapler, you need that. You can't downsize it. But you can say that it's a little bigger scar, but patients have no problem after closure, and we don't see it for last 1.5 year or last 2 years I'm using it. I don't see any problem with that. Neither patient complains about pain. And secondly, taking out specimen is beautifully simple. No need to struggle, no need to dilate. That's, we can say, the positive aspect of 19 mm.
Dr. Juneja, thank you for your interesting tips. I was wondering, I mean, rarely I have encountered a staple misfiring in the conventional classic sleeves. What would you think would happen, for instance, if you hit a hemo clip or something somebody had put in before your sleeve? If you hit this with a single fire stapler, what would you think would happen? I mean, would the cutting continue? What would you think would happen?
You mean any surgery done already on the stomach?
Not surgery done on the stomach, but like for any reasons you have a misfiring. What I was referring to, what has happened to me at least before, that the endoscopists, put in a little clip for a bleeding earlier, like years before, and then I hit that clip with a stapler, which caused staple misfiring. What would you think would happen in that single fire huge stapler?
Yeah, if any technically problem comes up in misfiring because of so-called inside some staple or some is there, then we can bail out easily. Once we bail out, then that area we have to consider it and decide accordingly what's the best. If it's really maceration has happened there, which I doubt will happen with the small staple inside, but if something happens, we can use either our suturing or we can use another stapler to do that part. Yeah, but it can be corrected, yes. And practically, I have not come across that kind of complication. So maybe you can highlight more what you did in that situation.
What I did, I was lucky enough to fit another stapler closer to that one, which obviously is not
Yeah.
ideal, but this is just
Yeah, that's the obvious answer. Yeah, we can do it if needed. Yeah.
Dr. Juneja, thank you for sharing those interesting videos. You showed some very difficult cases where you were still able to utilize the single fire stapling technique. In your practice so far in the past 2 years, have you ever come across anatomical difference or anything that prevented you from being able to use the single fire stapler?
No, till now, even the long stomach, thicker stomach, we were very cautious, but we had no problem. All the specimens came out nicely, and the sleeve came as beautiful as like any other patient. Yeah. So till now, no problems. Yeah.
Excellent. Thank you so much for your time and expertise and a wonderful talk. We're
Thank
now
you.
going to move to our final speaker, and we're elated to have Mr. Adam Dunki-Jacobs to join us. Mr. Dunki-Jacobs is an industry expert in surgical staplers and currently serves as the Executive Director of Research and Development for Teleflex's Surgical Business Unit. He's a former Chief Technology Officer and Chief Operating Officer for Standard Bariatrics. And over the past 20 years, he has contributed to the development of 2 manual and 4 powered stapling platforms. He holds over 50 U.S. patents specific to surgical stapling technology and is the technical lead in the development of the Titan SGS stapler. And he will talk to us on exposing the engineering science of the single fire stapler. Welcome, Mr. Adam Dunki-Jacobs.
Thank you, Dr. Johnson, for the introduction. Thank you to the IBC moderators and fellow presenters. What I'll be talking about today is the journey that we went on in the development of the Titan stapler. As Dr. Johnson mentioned, I worked for Standard Bariatrics and led the development of the single fire stapler. So we're going to hit on various aspects of the stapler once I share my presentation. Okay. All right. So the journey of the stapler. So there's several inputs that went into the development, and I know there's been a lot of conversation and questions around staple height and how do we generate the ideal staple height, and we'll get into that. But there's also some other aspects that over the years we get questions around. For instance, why is there no articulation? Also here, how do you get a curved sleeve from a straight device? How did you determine the staple line length of 23 centimeters? And then another aspect that people don't ask about, but it was an evolution, is the distal hinge architecture of the Titan SGS stapler. So what some people don't recognize, so several of the presenters talked about the clamp product that we launched prior to the stapler. And again, that was to understand the opportunity around reproducibility through the invention of this device. But there was also even another clamp that was a precursor to what we call our disposable clamp. And that is what we call the reusable clamp. And so I'll go into, as we went through this journey, all these different products, as well as a tissue mapping study that influenced the architecture of the Titan SGS stapler. So the reusable clamp, which not a lot of people have seen before, was FDA cleared in 2016. It was a clinical study device, and it was 25 centimeters long and reusable. You see a picture of what it looked like here. And really the importance of this device, you'll notice there's markings on the shaft or on the jaws of the device, and then there's two cables, and then the cables pull the jaws together. So we could get a lot of information from this device. The ruler on the jaws, we could start looking at video post-operatively to understand the length of the stomach that's being stapled. This device did have articulation on it. And then we were also testing the hypothesis of whether you could truly create a curved sleeve with a straight device. So when you think about the first aspect that helped establish the Titan SGS stapler architecture, it's the distal hinge. So initially, the reusable clamp had what we call parallel jaw closure via the cable system, and it kind of worked like a swing set, which created kind of a challenge for two reasons. One was the jaw would move, and it actually kind of grabbed the stomach as you're trying to manipulate it and pass it through the jaws of the device. The other was just the amount of real estate you had to work with up towards the diaphragm, up towards the GE junction. So a lot of the initial users of this device would develop this technique that they call the seesaw technique, but essentially they would push the distal end of the jaws together. And so this was really interesting. And so in the development of Titan, we started saying, hey, well, if we can replicate that with a hinge, it actually simplifies the architecture of the stapler. So that's how the distal hinge on Titan was born. And when you think about articulation, we get a lot of questions around articulation. Why doesn't Titan articulate? Well, the initial reusable clamp did articulate. And what we quickly found out as surgeons started using this device is that the distal tip movement puts tension on the stomach and then, thereby the GE junction. So what I try to do here is just illustrate this idea because it's kind of difficult to explain. But if you think about the device rotating about the trocar axis, the distal tip of the device is actually going to translate or move the most of anything on the device. I did some quick kind of geometry calculations here, but you can see that rotating the device 90 degrees at these different articulation angles, the amount of distance that tip translates during that 90-degree. So if you're, let's just say articulated 30 degrees, the distal tip, say if you're going to look at the posterior side of the stomach to look at retained fundus, would actually move 18 centimeters, which really doesn't work. You can't mobilize the stomach to the point where you can pull it 18 centimeters. So for that reason, we removed articulation as a feature, not only the disposable clamp that came after the reusable clamp, but also on the Titan SGS stapler. The last thing the reusable standard clamp helped illustrate or give us some insight into was, can we truly create a curved sleeve from a straight device? So Dr. Enochs and Dr. Ringold talked about the anatomy-based approach, where we physically would start marking the stomach at those three critical landmarks, and then placing the clamp along those landmarks, and the result you see on the right. So this helped validate the idea. When we first started developing the reusable clamp, we weren't sure if you could truly get a curved sleeve from a straight device. But this is what gave credibility to that idea, and further pursued into the Titan device. So after the reusable device, we made less than 100 of those that we shared with specific sites to help understand design inputs into future products. But shortly after that, in 2017, we launched our 25 centimeter version of our disposable clamp. And then later in 2019, we launched a 22 centimeter long version of that clamp. It's a disposable guide, just like the reusable clamp, but except the reusable clamp's reusable and the disposable clamp's disposable. But same idea, that you use it with 60 millimeter long staplers. And this really helped us establish jaw aperture for the Titan device, as well as finally establish the 23 centimeters as the ideal staple line length to accommodate all the variation in stomach lengths that we encountered. So as I mentioned, jaw aperture was important because for the device to function, we have to understand how far the Titan device needs to open. And what we noticed with a lot of the disposable clamp users is when they were positioning the stomach and the jaws, a lot of them would partially close the jaws, because otherwise the jaw would actually hit up against the top of the abdominal wall. So they closed it slightly, and they still had plenty of room to place the stomach into the clamp. And so at that point, we started understanding that and saying, what is our true aperture requirement for Titan? Because obviously the closure system of the stapler needs to be stronger than the disposable clamp. And so that's what informed our final jaw aperture of the Titan stapler. And in regards to the 23 centimeter staple line length, that was driven with that evolution of going from first a 25 centimeter long clamp. And then we had a lot of surgeons come and say, hey, it'd be great. You know, I've never had a stomach that wouldn't fit in that clamp. Can we get a slightly shorter version, especially for, you know, people with shorter torsos? The 25 centimeter clamp can be more difficult. So like, it would be great if there was a shorter version. So that's when we released the 22 centimeter long disposable clamp, which again, we had success placing stomachs in that length of clamp. So then that gave us, you know, arrived at the 23 centimeters, just slightly longer than the 22 centimeter clamp, as the ideal length for the Titan stapler to accommodate stomachs. So again, there's been a lot of conversation around staple height of the single fire stapler, and how do we arrive at that since there's no cartridge selection. So there was a tissue mapping study completed at the University of Cincinnati between June of 2016 and August of 2017, where 39 human stomach specimens were measured. So these are stomach specimens that immediately after surgery go across the hallway into a room where we could measure and biomechanically characterize the stomach. And what was unique about this study is we measured the thickness every centimeter along that resected line on the specimen side of the stomach, and we measured it at different pressures. And so that's significant because we know that tissue is a viscoelastic material and the stress and strain is not uniform. And so we have to measure it at different pressures to truly characterize that tissue. And along those lines, we also determined the pressure necessary to achieve the indicated staple height for the tissue. So when we measure the thickness of the tissue at 8 grams per millimeter squared, we know that the indicated cartridge for that is, say, a blue load if it's 1.5 millimeters thick. And so we actually characterize what is the real compression that we have to apply to that tissue to get to that closed staple height. So the key outputs of this study and the data from this study you can see on the left was we established that 15 grams per millimeter squared is the target pressure that our staples apply to the tissue to match, you know, what we're saying as an industry is the ideal staple height based on tissue thickness. And then when you project that, all that data over a 23 centimeter long length, you see what's on the left and we were looking at what is the shape or the nature of tissue thickness as it goes from antrum to fundus up to the GE junction, right? And so what we found is using a linear regression, we got an R-square value of 0.954. So it very closely matches a linear relationship between tissue thickness and distance from the antrum. So this is what feeds into the staple height that a lot of the presenters shared, right? So a couple things, right? So we get questions around, is the staple height segmented almost like cartridges today? So every 6 centimeters, there's a different staple height. The answer is no. We just follow the data from that trend line that I just showed you on the previous slide. And so the staple height increases by 0.02 millimeters every staple as you go from the distal end of the device to the proximal end of the device. And so that's really the science and the studies that we did behind driving staple height. So we did all that development work to say the design inputs for the staple height are, 1.2 at the distal end, form staple height, to 2.2 at the proximal end. But then University of Cincinnati did another study where they actually tried to do a head-to-head assessment to see how we compared to 2 other stapling manufacturers and related to not only burst pressure, staple height, and malforms, but also looked at, several other measurements of the stomach length and things of that nature. The other important thing to note on this is, a lot of times in development, we'll try to use, porcine tissue and things like that. Majority of the development of the single fire stapler was all done with human stomach. Again, taking that portion, that specimen side of the stomach following a sleeve gastrectomy, never refrigerating it, never freezing it, which affects the biomechanical properties, bringing it over immediately and using it for testing. And you can see what the researchers found in this study is that, what you're really looking at is the difference between the blue trend line and the red trend line. And that's the difference between staple height in blue and the tissue thickness, the measured tissue thickness in red. So ideally, you want the two to match, right? And so you see in the Ethicon group, the area between those two data sets is 1.77 millimeters squared, right? When you compare that to Medtronic, they were 1.98 millimeters squared. But the important thing to note there is Ethicon's blue line is above the red line. So that indicates that the staple heights are taller than the tissue thickness, so looser staples relative to the measured tissue thickness, while Medtronic was slightly tighter than the measured tissue thickness. And at the bottom, you can see the Titan group, and this was really the validation of all the development that went into Titan being a tissue-specific stapler, is that you can see that the tissue thickness and the staple height closely match. That's the closest match out of the other 2 groups, and the area between the curves was 0.32 millimeters squared. As I mentioned, another endpoint of this study they looked at was burst pressure. And so it is important to note that we did have the closest match to measured tissue thickness, but we also withstood significantly higher burst pressure. So the staple line itself performed better. And it is important to note, too, that one of the questions you may ask yourself is, well, how do you select the cartridge selection for Ethicon and Medtronic? And again, we use the tissue thickness measurements to use the manufacturing recommendations based on the measured tissue thickness to which cartridge we used in the firing. And this is for the firing along the entire length of the stomach to recreate a sleeve gastrectomy. So, and that's my final slide. So thank you for the opportunity to speak, and hopefully this was interesting information.
Thank you so much for sharing your insights and a bit of the story behind the stapler. I had a question about your head-to-head assessment. Has there been any head-to-head assessments with the robotic stapler? And if so, what were the findings?
Nothing that I'm aware of. So nothing to date that I'm aware of.
So I'm not a user of this, but I'm very impressed with what has been presented today. Did I understand it correctly that there's no articulation in this stapler?
That's correct.
So we sometimes, and I think I would invite a comment from other users if appropriate. Sometimes we operate on patients with large ventral hernia, class 3 obesity, lower abdomen is not accessible, and placing the 19 port in the lower abdomen is impossible because of hernia. And we usually, with our current multifier, we position our stapler, our ports much higher and work around that hernia. I wonder if anyone has come across that in a single fire situation and what was the solution to not having the articulation.
Yeah, thanks for the question. I have not encountered that situation that you described, but I will say that the most difficult patient to do a single fire sleeve gastrectomy on is someone with a really short torso, somebody that is really short overall, because you do need to have that, in my experience, 27 centimeters away from the xiphoid. But yes, I mean, that certainly could be an issue if there's a lower abdominal hernia or something of that nature that is in the way. You really do need to have kind of a sweet spot on the abdomen to place that 19 millimeter trocar. And if it's not really in the ideal location, it's going to make the case more challenging.
Thank you.
If I could add to what Dr. Ringold just said, that is a case where I had to abandon the use of a single fire stapler. Was a case like he described, where when we went in, adhesions came all the way up past the falciform. And I went in there, and it's like, in order to get the trocars in to use a single fire stapler, I would literally have to take all those adhesions down to do a sleeve. And I just did not want to do that. And so I ended up putting in trocars basically along the liver edge and just using multi-fire mainly for that reason. And it was due to the fact that I just did not want to take all those adhesions down to get the 19 millimeter stapler in.
I have done one case, not lower abdominal hernia, but infraumbilical Hughes hernia. So once we reduced the contents, after that, I was able to do without any problems. Yeah.
So, Dr. Dunki-Jacobs, I have a question for you again. When you develop your stapler and measure the ideal tissue pressure, I remember 15 grams. Did you also look at the potential blood supply and bleeding? Because I saw these nice data from Dr. Ringold that the single fire stapler less bleedings, and maybe it's because it uses a different pressure on the tissue.
Yeah, and so the idea of the 15 grams per millimeter squared is existing stapler manufacturers reference 8 grams per millimeter squared, but we know that they're over compressing. They're compressing the tissue more than that. So really all we were doing with establishing that 15 grams per millimeter squared was establishing what the other staplers on the market are truly compressing the tissue to. And then we're trying to then develop our technology to match that compression that's already the standard today.
But so this does not explain why the single fire sleeve has less bleeding, correct?
Why is less bleed? I didn't present any data with less bleeding.
No, you did not, but the Dr. Ringold did before, when I remember correctly.
Yeah, thank you for the question. I did not see any significant difference with a p-value, that was significant in regard to bleeding. Now, perhaps there was a trend towards less bleeding, but no, it was not statistically significant between the two cohorts.
But didn't you say, oh, the Dr. Enochs? Sorry, maybe I misunderstood, but one of you definitely said that the classic ones were used with seam guard, and yet the same bleeding rates, but using no seam guard in the single fire ones. Is that
Correct?
not
That's a great question, and thank you, Dr. Fink, for bringing that up. I can tell you, while there hasn't been a study that specifically shows decreased bleeding with the single fire stapler versus multi-fire and all the rest, the study that we did show equivalency between single fire stapler without buttressing and multi-fire with buttressing. If I had to, look at that and think about why that could be the case, of course, Adam is the expert when it comes to compression and all the rest. But one of the things that the same concept by which we talk about crossing of the staple lines, creating issues with the potential for leaks and other things, potentially those are, in theory, if you look at those crossing of the staple lines under a CT or something like that, you do see malformed staples and all the rest, which not only, as the FDA said, could increase the risk of leak, but potentially could increase the risk of bleeding as well.
No, thank you very much. That would explain that, yeah.
Adam, thank you so much for going into the physics of everything with the stapling device. Your comparison slide between the other leading competitors in the stapling field actually got me thinking, is there any thought process for standard making multiple fire stapling devices so I can switch to a better stapler for my bypasses as well?
You never know. You never know.
Great. Thank you so much, Mr. Dunki-Jacobs. Excellent presentation. And we really want to thank all of our speakers and moderators and participants for an excellent and thought-provoking discussion today. We have explored single firing stapling from multiple perspectives: technical, reproducibility, reflux outcomes, regional variation, and engineering design. And our experts have highlighted not only the promise and advantages of these technologies, but the importance of evidence-based and evidence-driven practice. I want to extend my sincere appreciation to Professor Ortiz and Professor Harris for their leadership, and Professor Ortiz will now close today's webinar. Thank you all for your engagement, and we look forward to seeing you at future IBC University of Oxford programs.
This has been an IBC Oxford University Hot Topics in Surgery production. I want to thank my co-chair, our moderators, and our distinguished panel of experts for their valuable time and talent today. We want to acknowledge all our partners and sponsors as our global collaboration produces safer and better outcomes. To view the complete Hot Topics in Surgery series, subscribe to our IBC YouTube channel and follow us on our social media platforms. And don't forget to mark your calendars, as the 7th IBC University of Oxford World Congress is taking place September 15th through the 17th of 2026. For more information, go to ibcclub.org. And now let's view another brief episode of IBC's exclusive Spotlight on Industry and today's sponsor. From IBC Global, stay safe and God bless.